Hello, everyone. Welcome to our last session of today. Just as we have started our other three sessions, we will be beginning things off with interpretation instructions for our attendees. As a reminder, if you are in the Zoom lobby, we invite you to join us in the webinar, and I will pass it over to Azucena to go through the instructions. Thank you so much.
Thank you very much. Can we start the interpretation, please, with Vic and Q? Okay, I will start, but it's better if the interpretation is enabled. Thank you. Thank you so much. Okay, so good afternoon, everyone. As you know, we are going to be offering interpretation into Spanish and Vietnamese. I'm going to remind quickly, folks, how to access this service in case you need it. Can you please go to the next slide? If you're joining us from your computer, please look at the bottom of your Zoom screen. You're going to see a globe that says interpretation. If you click on it, you'll be able to make your language selection. Next slide, please. If you are joining us from a cell phone or a tablet, please look for the three dots that say more. When you click on them, you'll see a menu that includes the language interpretation option. From there, you can make a selection of your language. Just make sure you click done after you do make your selection. And I'm going to ask my colleague Vic to go briefly to the English channel, and those of you in that channel should be able to hear him. If you do not, please let us know in the chat. Perfect. Thank you. I'm going to give instructions in Spanish now. Buenas tardes, bienvenidos. Como ya saben, vamos a tener interpretación disponible al español y al vietnamita. Y ahora les voy a recordarles las instrucciones de cómo tener acceso a este servicio. Si nos están acompañando desde una computadora, por favor, vean la parte de abajo de su pantalla de Zoom y van a ver un globo un icono de un globo que dice interpretación. Si hacen clic ahí, pueden elegir su idioma de preferencia y es todo lo que tienen que hacer. Next slide, please. Si nos están acompañando desde un celular o desde una tableta, por favor busquen los tres puntos que dicen más. Ahí si hacen clic ahí, se va a desplegar un menú que incluye interpretación de idiomas. Si hacen clic en interpretación de idiomas, van a poder elegir su idioma de preferencia. Por favor, recuerden hacer clic en listo o done después de haber seleccionado su idioma si están en un dispositivo móvil. Y ahora le voy a pedir brevemente a mi colega Vic que por favor se vaya al canal de español, los que estén en ese canal, y lo deben de poder escuchar, y si no, por favor, díganos en el chat. Yeah. Thank you.
Kính thưa quý vị biết là chương trình này có hỗ trợ về phiên dịch. Nếu mà quý vị dùng cái máy tính của mình á, thì có ba bước phải làm. Bước 1, quý vị bấm vào cái quả địa cầu ở phía bên góc phải bên trên. Bước 2, quý vị chọn cái ngôn ngữ mà quý vị muốn. Quý vị chọn vào chữ Vietnamese. Và bước thứ 3, bên góc tay phải cuối màn hình ấy, thì quý vị cùng bấm vào Vietnamese. Thế là xong. Và nếu quý vị mà dùng điện thoại di động á, cũng là 3 bước. Bước 1, quý vị bấm vào chữ More, có chỗ mà 3 cái chấm ở phía trên bên góc phải á. Và sau đó bước thứ 2, quý vị bấm vào ngôn ngữ phiên dịch. Quý vị bấm tiếng Việt. Và bước thứ 3, quý vị bấm vào chữ Done. Vậy là xong.
Thank you. Can we please be made interpreters, please?
Amazing. Thank you so much to our interpretation team for making this event accessible for folks speaking different languages. And again, another special thank you to the St. David's Foundation for supporting language access for the Texas State of Enrollment Conference. Friends, we have made it to the last session of day 4. As a reminder, we will be getting started again bright and early tomorrow morning at 9 a.m. Central, and we look forward to seeing you all tomorrow. after the conclusion of today's session. And an additional reminder, any resources, materials, slideshows, recordings that are shared during the TSOE conference will be shared with attendees after the conference. And again, I want to invite anyone who is currently in the Zoom lobby to join us in the Zoom webinar space. This way, you will have access to the Q&A box here in the session. You will have access to interpretation services, and you will be able to complete the poll at the end of today's session. And with that, I am happy to pass it to my colleague Sonia to get us started. Thank you so much.
Thank you so much, Katie. Welcome, everyone. As Katie said, this is the fourth session of our Texas State of Enrollment Conference's first day. And the title is Healthcare Options for the Uninsured, What is Available and Who is Eligible. My name is Sonia Lada. As Katie said, I'm the Outreach Director for the Texas Association of Community Health Centers. Today, I'm joined by one of my work colleagues and friend, Preston Poole, who is a policy coordinator here at TAC. And we're also joined by Paula Walker. She is the executive director for the Texas Association of Charitable Clinics. And then we're also joined by Esther Reyes, who is the campaign strategist for protecting immigrant families. So I know in the chat monitor, we'll be dropping in the Zoom events link so that you can read their full bios. And so thank you for that. Just to give you a little heads up of what we're going to be covering today, Texas will experience an increase in uninsured individuals, unfortunately, as a result of all the recent federal policy changes that we heard about this morning and this afternoon. And so this session will provide a review of what other options might be available for healthcare services that might be available in some communities, including community health centers and charitable clinics. The session will also provide a deeper dive into the impact of federal changes to Texas's lawfully present immigrant families who will no longer be eligible for coverage, and we'll offer some other helpful resources at the end. So the session's learning objectives are that participants will learn about other programs or services available to Texans who are uninsured, and that participants will have a general understanding of what some of those eligibility guidelines will be for these programs and where to find them in your area. And finally, hopefully participants will walk away with a better understanding on the impact of federal policies on Texas immigrant families and some resources available to help you mitigate some of those changes. So with these learning objectives in mind, we would like to remind attendees to please stay until the end of the panel to complete a quick poll for a chance to win the $50 gift card. If you're in the lobby, please make sure you join us here in the webinar in order to participate in the poll. Lastly, there will be a little time for Q&A at the end of each speaker's presentation and hopefully at the end of the session as well. So let's go ahead and get started. I'm going to go ahead and hand it over to Preston Poole. Again, he is our policy coordinator for the Texas Association of Community Health Centers, and he's going to talk to us a little bit about health centers and some of the eligibility and services we provide and how to find one. So go ahead and take it away.
Thanks, Sonia. Yeah, happy to be speaking with everyone today. And if you're not familiar with federally qualified health centers, hopefully you'll will learn some more about them today and the services they provide. We can go to the next slide. So federally qualified health centers, and for the most part in this conversation, I'll refer to them as health centers. There are 79 federally qualified health centers in Texas. These are organizations that are part of a federal program under HRSA, and you can find health centers in all 50 states and other territories. So in Texas, those 79 organizations operate over 700 clinic sites across 131 counties. and obviously also serve patients who come from other counties as well. In 2024, Texas Health Center served over 1.9 million Texans. This is a 5% increase from the previous year. And we'll dive in more about the kind of patient makeup, but you'll see, a large portion of health center patients are uninsured patients, as well as Medicaid patients, and while also accepting private insurance and other public insurance programs. So, very much open to the public, do not refuse patients, and very accessible to our communities. We'll dive in a little bit more into the kind of the rules that make up a health center and why they're so unique and important for their communities. We'll also just note, yeah, we can go to the next slide. What makes health centers unique is that they must follow federal guidelines in order to receive a yearly grant funding. And those guidelines include rules regarding how the organization operates, and that includes things like what services are provided, how patients are able to gain access, and where they are located. So, the first item would be making sure that health center clinics are located in areas of need. So, places where there are not enough providers or where not enough patients have access to a clinic setting. The second I think one of the most interesting parts about federally qualified health centers are they have a board in which the majority of the board is made of patient representative. So an actual patient, or it could be a parent of a patient. And that board is in charge of guiding the strategic workings of the health center. So determining what type of services are provided, maybe determining hours, or what type of focus or strategy the health center should be having. And so we have found that it allows these organizations to adapt to their communities, and so we like to say that once you've seen one health center, you've seen one health center. No two are alike, and I think a lot of it is because of this attribute. Health centers must be open to everyone. They do not refuse service to a patient based on their ability to pay. Health centers provide services, again, to uninsured as well as insured patients. For uninsured patients, they're eligible for a sliding fee scale. So depending on what their yearly income is, they're able to, the health center will only charge the patient a nominal fee for the services that they receive that day. And that goes up all the way up to 200% of the federal poverty level. And so we have seen that really creates access for patients in their communities. And we'll just mention real quick here some of the services, and we'll dive in a little bit more to that later. But all health centers must provide medical and dental services. They also provide behavioral health services. Many own their own pharmacies on site, so patients are easily able to get access to their prescriptions. And there are a number of other services, again, that they provide based on the needs of their community. The next. So again, just to kind of show you all a breakout of the types of patients that are seen. So a third of patients are uninsured, but then 29% are Medicaid patients, and 28% are private insurance. A note on our private insurance is that we saw a large uptick in private insurance patients in 2024, and our assumptions around that are that patients who maybe were disenrolled from Medicaid were able to take advantage of the enhanced premium tax credits and then enrolled in private insurance and came to health centers with that new insurance. So obviously we are paying attention closely to the ramifications around that policy issue. About 70% of our patients are below the federal poverty level. I believe it's about 98% of our patients are 200% below poverty or less. So again, a lot of patients who are able to come to our centers and take advantage of the sliding fee scale that we offer. And our patients are also, again, offered services regardless of their ability to pay that day. And many will, if services are more costly, many health centers also provide payment plans and other options for the patients to afford the care that they receive. Yeah, thanks. So again, there are a large number of services that health centers can provide. Primary medical care, dental care, some provide vision care, lab services, more specialty care. Many have OBGYNs and pediatricians. And so really try to be a medical home for a patient. And when I say that health centers offer these services, for the most part, these services are all offered under one roof. So when a patient comes in and they come in for a medical exam and they might find that they need some behavioral health services, that behavioral health provider might be able to be pulled in that day, or a service can be scheduled, back to back that day or on another day in the future. So really trying to provide, a one-stop shop for all medical needs. We also, many health centers also offer other enabling services, so transportation options, nutrition. Some have really great relationships with food banks or operate their own food banks, as well as case management and enrollment services as well. I'll also just add that the telemedicine part for health centers is very important. We serve a lot of people in rural areas and have found that the telemedicine option for patients has been very vital to keeping them healthy while reducing the barriers to getting health care, such as transportation or having to leave work. The next slide. So again, many health centers offer outreach and enrollment assistance. Many have their certified application counselors and case assistance navigators and community health workers. While they're not in every site, I will tell you that every health center wants to make sure that their patients are being enrolled and whatever coverage and assistance that patient is eligible for. So they will make sure that all patients get that service when they can. And so that includes, Medicaid, Medicare, Marketplace. Our health centers are ready to provide that additional service. You can go to the next slide. Included in all this, I think, again, health centers are really trying to focus on the needs of their community. And so along with that comes focusing on those non-medical drivers of health. So things like food insecurity, housing instability, reducing the needs, creating as much access as possible for patients to gain services. And I think, health centers must report yearly and publicly. You can go find it on the HRSA website, data regarding how many patients they are serving and the quality of care that they are providing, especially for chronic conditions such as asthma and diabetes and hypertension. all of those things are items that health centers both want to take care of, but also publicly report. And so you're able to see exactly how your health center is doing. It's a very cool aspect of the health center program, that you can see exactly how well your providers are doing at taking care of their community. Next. If you are interested in finding a health center, you can go to TAC's webpage, and you can go to the Find a Health Center portion of that webpage. HRSA also has its own Find a Health Center webpage as well. You can enter in your address or zip code. It'll show you a map of exactly where health centers are located, and find out more information about those. Next. Thank you.
Thank you so much, Preston. I didn't even have to give you a 2-minute warning. Any questions for Preston? We have a little bit of time. If anybody has a question about health centers in general. I just would like to say that I know many of our participants in the webinar right now are from community health centers. I know probably a lot of you know this information, but I'm sure there's some stuff that you heard that you probably didn't know about, because I find that the upskilling of outreach enrollment staff is so important. And I think that so many of you, as the slide said, there's about 435 outreach enrollment staff in health centers statewide. So it's a large group, network of assisters. And I'm just really proud of all the work y'all are doing. But some of you have been with us since the very beginning of open enrollment and the Affordable Care Act. So I just wanted to say a special shout out to everyone. Are there any other questions for, let's see, can we get a link to the website where you can find a report about services provided at any particular CHC? Preston, can you dig for that?
You can't while you can find a health center, that website will not show you all services provided. However, what I was mentioning before about data reporting, I can put a link in there, and you can see some general stats. I can't tell you that won't help you determine which clinic sites offer which services. That'll be something that you might need to contact the health center itself, if you're looking for a particular service at that clinic or organization as a whole. Yeah.
Great. Thanks, Preston. All right, well, I'm going to go ahead and move on. I don't see any more questions in the chat or the document. So let's go ahead and move on. Now I'm happy to introduce Paula Walker, and she is the Executive Director of the Texas Association of Charitable Clinics. And she's going to talk a little bit about her network of charitable clinics across Texas, and shares similar information that we heard on community health centers. So I'm going to go ahead and pass it over to you, Paula. Thank you so much for joining us.
Thank you for having me, Sonia. This is a real privilege to be with all of you today. And I'd like to just open up with saying thank you for all the work that you do. For those of you that work in the clinics, I also do too, and hats off every day. Just amazing work being done to help serve our communities. So I am Paula. I'm with the Texas Association of Charitable Clinics. We call ourselves TXAC, T-X-A-C-C, TXAC. And I'd like to share what we do as an association in our clinics. I always like to start with our vision and mission. Just centers me. We serve faithfully. We do not stop until every underserved Texan has access to quality healthcare. And we truly exist to advance the ability of our charitable clinics to provide the highest level of care to those that they serve. Advance. Thank you. So where do we do it? Is the question. So across the state of Texas, we have 75 free and charitable clinics. We have both. We have some free clinics and some charitable clinics. And we cover these counties that you see highlighted here. And I'm sure you've heard this many times today. But we have the highest uninsured rate in the nation. And a lot of those uninsured folks are children And sometimes that surprises people. And we, charitable medicine, our charitable clinics, we are privately funded, which is a bit of a difference. We do not we treat uninsured people. So if you have insurance, we're happy to find connect folks to places that like the federally funded clinics and other places that will accept their insurance. And we'll always take care of people, but we'll always make sure if they have insurance, we route them in the appropriate ways, because we have to see only uninsured folks. We are a 501c3, and we are funded through donors and grants. Our workforce is 90% volunteer. So people ask me all the time, how can you provide all this care and be free and charitable? And it's because we have a very strong volunteer workforce. And I think that's one of the things that differentiates us. Our impact and reach, the numbers I'm going to show you, the data I'm going to share is 2023 data, but in our 75 member clinics, we saw over 220,000 unduplicated patients in that year. That's about average for us. And we count patients just once. So a patient comes to see us, and it doesn't matter if they come see us once that year or 20 times that year, we count them as one, which is why we can share that we have over 500,000 clinic visits every year. And when I say visits in the fee-for-service world, these would be visits that would have a code and would be billed. Okay, so this does not include our education classes, our diabetes classes, our cooking classes, our exercise classes, our visits to our food pantries. It doesn't include any of those. These are just the medical clinical visits I'm reporting here. We know that we save Texas hospitals over $80 million a year. That's probably a very conservative number, and avoided visits to the emergency room. Next slide, please. We have a very strong rural presence in where we serve, and we base that definition off the state of Texas definition of what a rural area would be. And then we also do have quite a few clinics in urban areas in our larger cities like Houston, Dallas, and Austin. And like Preston showed you before, we too have our services are broad, but not every clinic offers every one of these services. So the beauty of being in a network like TexAC is that we are able to make sure every clinic in our network knows what clinics do and what they don't do, so that we can share our services. So for instance, I am a pharmacist. I work in a charitable clinic in my hometown in Grapevine, Texas, and I don't have in our clinic, we don't have dental services. But about 24 miles down the road in Fort Worth, we have a very large clinic that has a very large dental practice, 6 chairs and a full-time paid dentist. So any of our patients that need care, we have to connect them to that other clinic and get them on their schedule and help with transportation and all of that. So we work together. If we don't have it in the particular clinic, we work really hard to make sure we connect a person to another charitable clinic that can offer it. We too, like I mentioned before, a lot of uninsured, almost 900,000 now, I think is the right number of children. And of course, we all know that's going to grow. Are uninsured are children. And so TexAC has 2 freestanding pediatric only clinics, one in Dallas and one in Austin. And our one in Austin is actually a free clinic. And I believe it is the only free pediatric clinic in the United States. And so we have several other clinics that see both adults and children, which is very helpful too. We talked about dental care, mental health. There just cannot be enough, and all of our clinics are expanding in mental health services because it is such a need. Specialty care, the way this works is depending on the specialist who is volunteering their time. So we may have the specialist on site in our clinic. For instance, where I volunteer, I work with an endocrinologist every Tuesday night. So we do it right there in the clinic. But I also have a dermatologist on our staff who likes to see the patients in her office because she's pretty close to the clinic. So our patients go over to her office because she has all her stuff and it's convenient for her. So she just stays open after hours. So it all depends, but we just do our best to get the patients the right specialists that they need, and make it as easy as possible. And then, of course, pharmacy support, that varies too. Some of our clinics have a full-fledged Class D clinic pharmacy, and then others have like a medication closet, and the pharmacist really is on site to support the patients, always do a medication reconciliation, and connect the patient to affordable, free or affordable medicines. Thanks. So as from the association point of view, we are probably much like federally funded association. We are here, TxAC, to support our clinics. They are autonomous. We do not govern, we support. And we do this through this list of things. We have monthly calls, so we stay together, a tight-knit group. We have work groups that we work on initiatives together. So it's always the voice of the clinic, because every community, as this was mentioned, is different, and what they need in that clinic is unique. So right now, one of our work group is to work with Texas State University, who has great research. They do a lot of great stuff in diabetes, but they don't have a medical school. So we have a bunch of charitable clinics, and they need places to send their students and their researchers. And so we work together. Before we did that work group, we were doing some advocacy work group things. So it's always something, but we do it together as a group. And then we hold a conference for our members, our clinic members, every year. And just like, an educational conference, like you've probably been to yourselves. And we have a good time of fellowship, and we learn a lot. We have a leadership retreat. But really, one of the most important things that we do is TxAC, we are the data hub for 75 clinics across the state of Texas. So every year we make sure our clinics sign up, renew their membership, fill out an assessment form and an operational standards form. And that is the seal that you're looking at. That's very important to us, because we want to make sure that all of our clinics meet our operational standards, which we hold even higher than our national operational standards. And so that we can show our donors and our funders that we are offering the best care possible. And most of our clinics are gold sealed. We have some that are silver sealed, and that just gives TxAC the opportunity to help get those folks all up to gold. And so we also watch out for grant opportunities for our clinics, of course, and connect them to medications. I mentioned educational opportunities, and that's so important in this. Just what a busy year we had here at TxAC, because it was a great year to do some refreshing education with our providers and staff on measles. That was really important. We made sure we got that done. And then also with avian flu or bird flu is another thing that we spent quite a bit of time on today, making sure that we are ready. We hope we never have to face something like that, but just making sure that we're all ready. So disaster preparation is very important to the association. And as we saw in what happened in Kerrville, which we had with our flooding in Texas, we had a clinic right in the middle of all of that. And so we had to have, our plans so that we could stay connected and start serving right away, meet the needs there. And you can only do that if you're ready. So, and we did okay. We did a pretty good job. I think we were helpful. And now we are renewing our disaster preparation plan, because there's no better time than after disaster to do it. So that's just another way we support our clinics and our community. We could advance, please. Okay. This is very important to me. This is really where I think I like to spend some time when I'm talking about what our clinics can accomplish in our communities. And it is our job's impact. So most of our patients are working. The majority are working. Someone in the family that we serve are working people, but they are working very low paying jobs, very, very low paying jobs. And they may not be offered insurance. They may not be able to afford their insurance. And there's nothing that makes a person more vulnerable in their work especially in a low-paying job, is to have an unmanaged disease that prevents you from going to work or causes you to have maybe an incident at work, a health-related issue at work. We want to make sure our patients are never put in that situation. So our goal is to keep people healthy. If they have a chronic disease, which you may already know, in Texas, we're #2 in diabetes. Add that to being #1 in uninsured. It's like a perfect storm. So we have lots of people to help, which is why I'm so grateful that federally funded clinics are here and that charitable clinics are here so that we can help as many people as possible, not fall through the safety net and not get, in trouble, lose their work, not be able to take care of their families. So it's very important to us that we are sustainable and that we do a good job reaching the public and letting them know that we're here, which is why I'm so grateful that you invited me, and that we are open for business, and that we, sometimes in charitable clinics, sometimes if people can pay a little bit, that's great. But if they can't, nobody gets turned away. So bottom line, really to sum up what I have to say about what we do is that charitable clinics do our best to keep Texans healthy. We want to keep people working so that they can support their families. And as someone, I'd just like to close in saying, as someone that's been in healthcare 35 years, I've worked in charitable medicine for 20 of those years. I didn't even really understand the difference between a federally qualified clinic and a charitable clinic. And our differences are few, but our commonalities are many, I think. And that's why I was so excited to even just be invited to come and meet you and hear more about the work you do. Because if I could be in healthcare that long and not really understand the differences, I'm sure so many others don't know who we serve and why we serve and why we have the heart to serve that we do. And I'm just really happy to come here and share that today. So thank you. And I thank you for your time, and I'm happy to answer any questions you have.
Great. Thank you so much, Paula. I learned so much about your organization and just the services. Thank you so much for that overview, and so happy to have you share the space with us and let our sisters know, just what's out there. The last slide here shows a QPR scan code where you could find a charitable clinic near you. There was a question, Paula, and I think it was directed for you, but it says, can someone approach you to start a clinic in an area that you don't currently serve? Or how does that process work?
That's a great question. Thanks for asking that, because yes, so one of the things TxAct that has is a resource center. And so our members can go to that resource center and answer that question. So I want to start a clinic. And so we have resources that say, this is how you start a clinic. Sometimes, unfortunately, people want to close a clinic. We have resources that teach you how to close a clinic legally, properly. So to answer that question, so could someone approach you to start a clinic? Absolutely. There's a lot of information to be shared there, but so too much obviously for a meeting like this, but absolutely call me. There you have my direct line right there, my email, whatever works easier. But yes, that is a very important part of what we do is making sure that clinics know how to both open and close, and in between, make sure that they're doing everything properly legally, and that goes back to our quality standard, our operational standards.
Great.
Making sure that we have gold sealed, silver and gold sealed clinics out there doing great work.
Awesome. And so is some of that information on your website when you talk about the resource center? So they can go to the website and look there as well too.
Yes. So what I would recommend, someone who's not a member may get only so far. They probably can't get into our resource library, but that's not a problem at all. So we're here to share all of our information. So just read. I would say email myself or Carolina is usually our first. We're just a we're a 2-person operation at Texac. So whoever you get is going to help you as best we can. So yep, reach out to me. I'd love to talk to you about that. We can't, one of the things I said I don't know if I said, but on my slide, we know that where there's a charitable clinic, people lose less work days. And we also know that where there's charitable clinic, 30% less people go to an emergency room for avoidable emergency room visit. And so we know that we have a lot of impact. But if you looked at our map and saw where we are located, and then Texas is such a vast state. I mean, there's so much territory that's not covered yet by a charitable clinic. There's so much work out there to be done. And so, yeah, that we're in the business of helping people, and having charitable clinics in communities is really important and impactful. So we're here to help you do it.
Wonderful. Well, we look forward to hopefully seeing that network of charitable clinics expand in the future, especially as the needs increase and these programs become harder to come by for a lot of our Texans. But thank you again, Paula, for all your information. Now we're going to go ahead and turn it over to our final panelists. And I'm really excited to have Esther Reyes with Protecting Immigrant Families join us. And she's going to dive a little bit deeper. I know we talked about immigrant categories this morning and some of the immigration issues at the federal level. And this is really kind of a review of that information again. And I don't think there's anything wrong with hearing this stuff again, because it's just so complex and so much information. And so without further ado, I'm going to go ahead and pass it over to Esther, who's going to share kind of maybe a little Texas lens and also some resources that are available for our immigrant families. Thanks, Esther, for joining us. Take it away.
Thank you so much, Sonia. And I also want to thank everybody who is here, to all of the enrollment assisters, everybody who works in clinics or in the administration of clinics, or in associations. All of your work is so critical and valuable and not unseen. So thank you so much for the work you do. And as Sonia said, I'm going to be talking about the biggest changes to immigrant eligibility and access to healthcare coverage. So next slide. Under the first Trump administration, we saw many attacks to immigrant families that drove fear into these communities and led them to go without seeking care, or not enrolling themselves or their children for benefits that they were eligible for, and concerns that accessing benefits would impact their immigration status. And so many of you were on the front lines of hearing these concerns and elevating these challenges that ultimately led to the creation and efforts of the Protecting Immigrant Families Coalition and Seguro Texas. Today, we're seeing even more cruelty and chaos under this administration, as well as Governor Abbott's direction. And the escalation of anti-immigrant policies are creating fear and confusion among immigrant communities. So one way that you can be prepared is by clearly understanding some of these changes, as we also work to dismantle and advocate for the future that we all want to see. Next slide. So HR 1, which is, or OBBA, the bill that was passed in July, made sweeping changes to the ways that immigrants access public benefits, while also funding more immigration enforcement and extending tax cuts for the wealthiest of the wealthy. I'm going to be focusing on some changes to Marketplace this upcoming enrollment period and the next, but I also, as Sonia said, want to briefly review the changes to Medicare and CHIP, or Medicare and Medicaid and CHIP. So as you can see on the screen, effective this past July, only lawful permanent residents, Cuban and Haitian entrants and individuals from COFA nations will be eligible for Medicare, and current enrollees in Medicare will be disenrolled by January 1st of 2027. And this includes refugees and asylees, victims of domestic violence and trafficking, and other statuses, and you'll see those listed in a minute. And then effective October of this year, the same group, that smaller group of immigrants, including lawful permanent residents, certain Cuban and Haitian entrants, and individuals from COFA nations will be eligible for Medicaid and CHIP. Still, when applicable, the 5-year bar and 40 quarter work hours will apply. And in Texas, ICHEA will continue to apply for children. Next slide. Now, the big change that you all need to be aware of for this enrollment period to marketplace eligibility is that low-income immigrants below 100% of the federal poverty level will no longer be eligible for financial assistance to subsidize their plan. So they will still be able to purchase marketplace coverage, but it would be at full price. And for the next enrollment period, many lawfully present immigrants will no longer be eligible for financial assistance to subsidize their plans. Let me go into these a bit more. Next slide. So this table describes the change that goes into effect this enrollment period in greater detail. Because many lawfully present immigrants are excluded from Medicaid precisely because of immigration status, the Affordable Care Act created a door for low-income immigrants to get financial help and buy marketplace coverage, even below 100% of the federal poverty level. Starting this enrollment period, any lawfully present immigrant below 100% of the federal poverty level will no longer be able to get financial help to purchase marketplace plans. So this new law essentially closes a door for low-income and lawfully present immigrants to access healthcare coverage, effectively creating a new coverage gap. Next slide. Oh, not that one. Actually, the one before. Yes. Okay. Now, this table describes a change that will go into effect in the next enrollment period. As you all know, when anyone goes to buy a marketplace plan, they estimate their income for the coming year. And based on that estimate and other factors like household size, they can qualify for advanced premium tax credits or APTCs. These tax credits essentially make it affordable for people to pay for monthly premiums. And since the beginning of the ACA or the Affordable Care Act, a list of lawfully present immigrants, which is the list on the left, and there's a link there for the full list. These immigrants have been able to receive tax credits, just like their US citizen counterparts, to actually buy health coverage that is more affordable. Now, the change coming now is the list of who is eligible for these tax credits is now greatly reduced to only include a small subset of lawfully present immigrants listed on the right side. And as you all know, DACA recipients have been ineligible since December of last year, and undocumented immigrants are altogether ineligible to enroll in Marketplace, even at full cost. Next slide. Okay, so in this chart, we can see how these changes combined impact immigrants in Texas. So on the far left, you'll see US citizen children and non-citizen children may be eligible for Medicaid, CHIP, premium tax credits, and cost sharing reductions based on their family's household income. And as you may be familiar, US citizens and a very small group of immigrants may be eligible for financial help above 100% of the federal poverty level. Now, the two columns on the right show the new changes created from HR 1. And here you can see the newly created coverage gaps below 100% of the federal poverty level, where no lawfully present immigrant can access Medicaid or ACA coverage. Above 100% of the federal poverty level, lawful permanent residents, Cuban and Haitian entrants, and COFA migrants will still get that financial help for marketplace coverage. And then the far right column, you can see the other lawfully present immigrants above 100% of the federal poverty level can still purchase plans, but they will not be getting any sort of financial help to do so. Next slide. Now, there are going to be a lot of impacts from HR 1 and the changes that it created in our communities, and our communities are going to feel them, especially, they're going to begin with immigrants. With the changes that I talked about combined, the Congressional Budget Office has estimated that over 1 million, or about 1.3 million immigrants across the country will become uninsured, which means that their access to healthcare will be undermined. And as previous panelists have mentioned, their financial security will be put at risk. Now, from the changes to low-income immigrants, we estimate that 300,000 will lose coverage and won't have another pathway for affordable health insurance. We don't have clear estimates for how many people this will impact in Texas, but the enrollment data from the last enrollment period show that more than 80,000 Texans who were below the federal poverty level were enrolled in marketplace coverage. This number isn't broken down by citizenship status, so we can't say for certain that they're all immigrants, but that coverage was only affordable to those lawfully present immigrants who were ineligible for Medicaid. Everyone else would have paid for full-priced coverage plans. Next slide. Okay, I also wanted to provide a few updates on recent changes and actions by the administration that impacts our work. So in July, the U.S. Department of Health and Human Services published a notice that reinterprets the meaning of federal public benefit in the 1996 welfare law. This notice says that HHS considers an additional 13 programs as federal public benefits, with eligibility restricted to qualified immigrants. It did not change eligibility for Medicaid or CHIP, and states that provide coverage to lawfully residing children, immigrant children, and pregnant people can continue to do so. The notice also confirms that nonprofit charitable organizations are not required to verify immigration status. Now, the important thing here is, as you'll see on the screen, there was an active lawsuit that was filed by 20 states against the Trump administration. Texas was not one of the plaintiffs in that lawsuit. But as a result of the lawsuit, there was an injunction, meaning that this notice would not apply to the states who were part of that lawsuit. However, as you can see there in the orange, to date, no additional program guidance has been issued by the Department of Health and Human Services. And so we do want to emphasize that until we get guidance, it should continue to be business as usual. Okay, next slide. Another update. in June, the Associated Press reported that the Trump administration shared the personal data of Medicaid enrollees in California, Illinois, Washington, and the District of Columbia with the Department of Homeland Security, or DHS, for immigration enforcement purposes. As a result of that, the state of California, along with 19 other states, not including Texas, filed a lawsuit against that data sharing. Later that month, the AP reported that CMS and the Department of Homeland Security had entered into a new data sharing agreement that impacted all 79 million Medicaid enrollees across states. Later in August, an injunction was ordered that the Department of Health and Human Services stop sharing Medicaid data with DHS, or the Department of Homeland Security, in the lawsuit that was led by California. We are still waiting on the outcome of the lawsuit, and we'll keep everyone posted. But we wanted to make sure that this was on everybody's radar because, of course, it's data sharing and privacy concerns are top of mind for many of the people that we work with. And then finally here, in August, CMS announced a new oversight initiative promoting a narrative that ineligible immigrants are receiving Medicaid. So now CMS is running TMSIS, or TMSIS data that states report through the SAVE system, and is sending a monthly letter to states with a list of enrollees whose eligibility was not able to be verified by CMS due to their immigration status or U.S. citizenship status. CMS now is expecting to go back and for states to go back rather and check the immigration status of people who are getting Medicaid or CHIP, and to get more information to verify that eligibility. Texas was not included in that first batch, but it's still important, about what can we say. It's so important to think about what we can say to these enrollees, including encouraging folks to regularly check their mail and their accounts, have their documents ready in the event that they're asked about them. Of course, only include Social Security numbers for enrollees, etc. And I believe there are some a document dropped in the chat that includes some talking points about data privacy and just in general, right? Like what's happening with data sharing and everything that the Department of Health and Human Services and CMS is now doing in the chat. Next slide. Okay, so as I mentioned earlier, your work and our work is so critical, and it's as important and as ever. The PIF Coalition, Protecting Immigrant Families Coalition, we are a national coalition of over 800 organizations across, I believe, 43 states, maybe even more, that is committed to defending access and expanding access to benefits for immigrants. And so the work that we are going to be doing, and that we really encourage all of you to join us in, is to work with us as we continue to develop community-facing materials and resources that we can use for as we're working directly with communities. We'll also be developing ways, simple ways to document the harm of these new restrictions. We want to make sure that we don't let these restrictions and the impact of them go unnoticed or undocumented, rather, for lack of a better word there. We want to make sure that we can document those and the impact that they're going to have on our communities. And finally, we'll continue to monitor and monitor all the updates and changes and lawsuits and new actions that continue to come down, and then educate our partners at the state level and local levels and national levels about the implementation of these policies. So we definitely encourage you to join us. Our information is there in the chat. And I think I'll hand it back to Sonia now and see if we have any questions.
I think you have one more slide. Didn't you have another one? I thought you had a resource slide.
Oh, I did. I'm sorry.
Well, that is my bad. I apparently, when we were converting the slides over to Canva, the converter eliminated slides here and there. So we apologize, everyone, for that. But I'm wondering if we could just share that last slide. Is there a way somebody can just?
You know what? I have it, and I can just copy it and drop it in the chat.
Sure.
And then we can also share that with folks.
Great.
Here.
And I'm pulling the links from the resource page and dropping them in the chat as well.
Okay, that's probably better then. I'll let you do that.
So do you want to talk a little bit about those resources? I know a lot of them were
Yes.
like updated information, which I think a lot of
Yes.
our participants are really hungry for.
Yes, absolutely. So, yes, in that final resource page, you'll see a number of resources, including explainers and short just summaries on a variety of the things covered here today. So there's an explainer on the provisions on immigrant access to public benefits in the final reconciliation package, or HR1, that includes not only healthcare, but also programs like SNAP and the child tax credit. We also have an explainer with a lot greater detail on the notice on federal public benefits, some resources on data privacy, and messages that you can use to share as you're talking to communities about this. These were updated this August, as well as public charge community resources, also updated in August. And then I provided a link to immigrant-related resources by the Center on Budget and Policy Priorities, which many of you will be familiar with, but I wanted to make sure to include that there. And of course, our good friend, who many of you know, Carla Martinez, who is Senior Policy Analyst at Community Catalyst, supported these slides and is doing also great work. And so her contact information is also there if you want to get a hold of her.
Great, thank you. And many of you don't know, but Carla was initially going to do this presentation for us, and she had to bow out. But Esther was gracious enough to step in and take over and did a great job covering a lot of the information that I think we couldn't cover this morning in a little more detail because we were sharing that session with other federal policy updates. But let's see if, I'm just going to take a moment here to see if there are any questions that anybody wants to bring to my attention that I maybe have not seen. Not seeing any questions.
There's one for Paula, Sonia.
Oh, okay.
Yeah, Paula, it's just it's for about the TxAct clinics. Do people who go to the volunteer clinics, do they have to have local addresses to get services from those clinics? Or is like, I guess, yeah, what's the kind of like vetting process like? Like, do you have to be a neighbor?
When a patient comes into the clinic, and it really depends on the clinic, to be perfectly honest, Lynn. So it's a great question. And because all of our clinics, they're autonomous, they do what's best for according to their community. I would say for the majority of the clinics, anybody can come to the clinic. They ask for your name and an address, and that's pretty much it. I can definitely speak from my clinic that we try to serve our community. So we have 4 or 5 cities that touch Grapevine, and we serve those cities. And then if we notice that a patient is actually closer to a different clinic, we'll take care of them. We'll always take care of people. But then if we see that they really fall into someone else's community neighborhood, then we will connect them to that clinic. We just do that so that patients are really being taken care of the best by their community, if that makes sense. And then again, if they can be taken care of by, public hospital system, or if they have insurance and didn't know it, we're going to connect them. But they're always going to be taken care of, and we do our best. Now, if we can't find that the right, no one gets turned away. Bottom line, no one gets turned away. So we try to serve other, the areas that we advertise that we serve and that we say that we serve, but no one gets turned away.
Great, thank you for that, Paula. I'm not seeing any other questions. Well, I'm going to go ahead and thank our panelists, Preston, Paula, and Esther. Thank you so much for spending a little bit of your afternoon to talk to our enrollment assisters across the state and give them some more information about your programs and your networks and your resources. I'm going to go ahead and pass it over to Katie to close us out.
Sonia, we actually just got another question, and Simona just pasted it into
There it is.
Yes.
So, okay, so it says, I live in a predominantly immigrant community and many are leaving or isolating. For advocates, what can I tell them, especially with all these provisions taking place? Is that question about like, what do you tell them as far as applying for coverage or seeking health care? Does anybody want to respond to that? Paula, you have your hand up.
Yeah, that's a really great question. Thank you for letting me respond to it. Because we are seeing that, and we're seeing more missed appointments and patients staying home versus coming out for care. And so what we do is we do our very best to provide a safe place and to make sure people are aware that we are following the letter of the law, that we are posting the right signs, that people cannot enter our clinics without can't think of the word, when you need it from a judge to come into,
Warrant.
people. A warrant. We do our best to educate patients that, how to protect themselves and what to say and how to answer questions and not answer questions. And so this is impacting us, absolutely is, but not as much as we feared it would. So the idea is to provide a safe place, have that trust. And again, we just ask for patient's name. We want patients to have an address. So they can provide us with address, but we keep that information to ourselves, and we don't share it. And we let our patients know that their information is protected, and that their security and their safety is our number one priority. And I think an interesting thing that what we've noticed is haven't seen it as much in my clinic because I see patients over 19 to 64. We have seen more of patients not coming in with children in the pediatric clinics. And I think that is, we think, to the best that we can come up with is that just, it's an additional fear of a parent not being there for their child. And so we think it's impacting our pediatric visits a little harder than it is the adult visits. I hope that answered the question. It's a great question. It's really a concern right now.
Yeah, it sure is. And there's a follow-up for those seeking care and protections, I guess is what they wanted to clarify about what can we tell them. And I'm wondering if anybody, has any advice for this person. I know that a lot of us are struggling with what we can say to our families because there's a lot of unknowns. We don't know what's being shared, for example. We don't know what's going to be shared if that communication between agencies continues to happen at a national level. But I think that, right now it's business as usual, I think, for a lot of us, especially when we talk about the issue that Esther brought up on the federal public benefit. I know there's been a concern with our health centers because the health center program has long been not on that list and is potentially on that list now, or is on that list of defined federal public benefit. And so our advice to our health centers is that we continue providing the care that we have just as we have before until we get further guidance. But just wondering if there's anything else that maybe Esther or anybody else on our panel or anybody on our host panelists group wants to chime in before we close out.
Thank you, Sonia. I will emphasize what Paula said as far as ensuring that the clinics and the centers are prepared and knowledgeable about the security measures that can be put in place at those sites, right, for the safety and security of people who access them who are immigrants. And so we definitely encourage that. And then the other thing is really to just be honest and upfront with the communities that we're working with and the immigrants and the concerns that they have, and help them weigh the benefits and the risks of seeking care, and making sure that we also empower them with agency to make that decision, because ultimately they are up against a lot of things, right? And we want them to know that we're here and that we are doing as much as we can to promote their safety and their security, and give them the information that they need to be able to make those decisions accordingly.
Great. Thank you so much for that, Esther. We are out of time. I think we will need to just go ahead and move on. I know there's another questions in the chat, so we will get all of those into our Q&A documents and make sure that we share those Q&As afterwards. But I'm going to go ahead and turn it over to Katie to close this out.
Thank you so much, Sonia, and thank you again to all of our speakers and all of our attendees on day one of the Texas State of Enrollment Conference. If you are in the Zoom webinar space, so not our friends in the lobby, we are about to start our poll. So again, 3 questions about today's session, and I will read those aloud as soon as the poll is launched. There it is. And after I read through the poll, we will be drawing, excuse me, our last winner for today. So question 1. I learned about other programs and services available to the uninsured in Texas. I strongly disagree, neutral, agree, strongly agree. Number 2, I have a general understanding of eligibility guidelines for these programs and where to find programs in my area. I strongly disagree, neutral, agree, strongly agree. Number 3, I have a better understanding of the federal policy impact on Texas immigrant families and resources available. I strongly disagree, neutral, agree, strongly agree. Thank you again, everyone, for filling out that poll. And Simona has pulled all of the names of our attendees, and she is spinning the wheel. And our winner for session 4 is Cindy Bustos. Apologies if I'm saying your last name incorrectly, but congratulations, Cindy. If you can just give us a little wave by the raise your hand function or respond in the chat. Again, our winner for session 4 is Cindy Bustos.
Bustos.
Cindy, did we get our hand raised? There you are. Congratulations, Cindy. We will be in touch with a form for you to fill out to receive your $50 gift card. And with that, friends, we have finished right on time, which is pretty exciting as a conference organizer. Thank you all again today for joining us for the Texas State of Enrollment Conference. We will be getting started again at 9 a.m. tomorrow morning, Central Time. We have 2 sessions tomorrow. We're really excited. We're going to be doing some resource sharing. And then session 6 is actually an opportunity for you all to get to connect with other assisters in your area. So very excited for tomorrow. We hope you all have a wonderful afternoon and evening, and we will see you again. Thank you so much. Have a great evening.